achieved. To repeat, it's generally recommended that the site be developed at a rate of 1 millimeter in depth for each addition of packed graft particles added to the osteotomy. In the case at hand, since there was an initial subantral bone height of approximately 4 millimeters, in order to receive a 7 millimeter implant, it was necessary to elevate the sinus floor at the implant apex by 3 millimeters. And therefore the cycle of adding graft particles and advancing 1 millimeter each time will need to be repeated a total of 3 times. At this point, the full depth of 7 millimeters has been developed with the regular or 4.1 millimeter diameter, 7 millimeter long trial fit gauge. However, since it was intended to place a wide body or 5 millimeter diameter Endopore implant in this site, it was necessary to use the 5 millimeter wide by 7 millimeter long trial fit gauge as the final osteotome tip, and to seat the conical portion of this trial fit gauge to its full depth of 7 millimeters. This wider diameter implant is preferred to facilitate development of the appropriate emergence profile for a molar crown. After withdrawing the trial fit gauge, it should be verified that a distinct sealing of graft particles can be seen at the apex of the osteotomy, and if so, the implant is ready for placement. For this molar tooth site, a 5 millimeter diameter by 7 millimeter long external hex Endopore will be used. The implant is carried to and immediately inserted into the osteotomy site, taking great care to avoid contamination of the sintered porous implant surface. The implant is seated as far as possible using digital pressure on the plastic carrier handle, following which the handle is snapped off and discarded. As quickly as possible, the implant driver tip, connected to an osteotome handle, is used with the surgical mallet to drive the implant to its fully seated position. It should be kept in mind that since the implant is being placed in primarily cancellous bone, that this driving tip should be used with the same orientation as the osteotomes had been used to develop the osteotomy, in order not to change the desired implant orientation at this late stage. Tapping the implant in a direction other than the intended original orientation could lead to tipping of the implant and a less than optimal orientation. If properly placed, only the healing cap of the implant should be visible above the bone crest. By submerging the whole implant length, including the machined collar segment, and assuming that there's adequate cortical bone thickness on both the palatal and buccal aspects of the osteotomy, any crestal bone loss related to surgical trauma that will occur during the initial site healing will be limited to the machined collar segment and ensure successful integration by bone ingrowth into the porous implant surface zone. The implant replacing the second premolar tooth was then placed into its prepared osteotomy. As before, the implant is removed from the sterile inner packet immediately before use and promptly placed into the final osteotomy site, using firm digital pressure on the plastic implant carrier handle. Then, after disconnecting this handle from the implant driver tip and surgical mallet are used to fully seat the implant into its osteotomy site. As a final step before wound closure, the implant hex driver should be used to ensure that the implant healing caps have not loosened during the tapping procedures, and that the implants are completely secure. As with all dental implants, complete initial implant stability is crucial to successful osseointegration. The surgical field can then be irrigated generously with sterile saline and the flap replaced and secured with sutures of the operator's choice. Some release of periosteum may be necessary to ensure a passive wound closure during suturing. Regarding the postoperative period, because the actual sinus elevation is minimal when using 7 mm long Endopore implants, the patient should experience no side effects from the actual sinus elevation procedure. A periapical radiograph of the implanted sites was taken immediately after site closure. This radiograph shows that the implants are well positioned and that there is a well-contained area of graft particles about the apex of the distal implant. Because the graft used is only osteoconductive and is slowly resorbed, the implants in this case will be left to heal for at least 5 months before undertaking the re-entry surgery. A further 1 month will be allowed for soft tissue healing after the re-entry, so that in total the implant sites will have had a minimum of 6 months of healing and graft site maturation before prosthodontic restoration is begun. The mandibular right first molar tooth site will receive a single-stage internal connection Endopore 7 mm long implant so that both sextants can be ready for restoration at the same time. In summary, in this video, we've demonstrated the use of the indirect osteotome-mediated localized sinus elevation procedure to facilitate the placement of 2 7 mm long Endopore dental implants to replace the missing maxillary right second bicuspid and first molar teeth. Because of the unique mode of integration of sintered porous surface dental implants, this procedure can be done in as little as 3 mm of existing subantral bone, in sites that would need open lateral window sinus elevations to be treated successfully with threaded dental implants. It's a highly predictable, cost-effective, and minimally invasive procedure when used with the 7 mm long Endopore implant, and greatly simplifies the restoration of the resorbed posterior maxilla.